Epidural injections for sciatica work very well for some people and barely at all for others. And the difference almost always comes down to a specific set of factors that most patients are never told about before their procedure. Tonight I am explaining exactly what those factors are, what the research actually shows about short-term versus long-term results, and the specific questions worth asking your doctor before deciding whether this is the right next step for your sciatica. My name is Dr. Michael Kent, 20 years working with seniors managing sciatica. Drop a comment below, your age and your city. Now let us get straight into this. What an epidural injection actually does. An epidural steroid injection delivers a corticosteroid medication directly into the epidural space, the area surrounding your spinal cord and nerve roots, at the specific level where your sciatic nerve is being compressed or irritated. The steroid reduces inflammation at that exact location. It does not remove a herniated disc. It does not fix a narrowed spinal canal. It reduces the inflammatory swelling around the nerve root, which in many cases is what is amplifying the pain signal beyond what the mechanical compression alone would produce. This distinction matters enormously. An epidural is treating the inflammatory component of your sciatica, not the structural cause. If inflammation is a major driver of your pain, the results can be significant. If your pain is being driven primarily by severe mechanical compression with minimal inflammatory component, the injection has less to work with. Who tends to respond best? Research consistently identifies several factors associated with better epidural outcomes. Sciatica caused primarily by a disc herniation with clear inflammatory component tends to respond better than sciatica caused by long-standing spinal stenosis with minimal inflammation. Pain duration under 6 months tends to respond better than pain present for several years, where central sensitization and secondary muscular compensation patterns have had more time to develop independently of the original inflammatory trigger. And patients who combine the injection with active rehabilitation, movement, nerve mobilization, and physical therapy during the window of reduced pain tend to maintain benefits longer than those who use the injection passively without addressing the underlying mechanical and lifestyle factors. The repeat injection question. Most pain management guidelines recommend a maximum of 3 epidural injections per year at the same spinal level, with most physicians spacing them at least several weeks apart. This limit exists because repeated corticosteroid exposure carries its own risks, including potential effects on bone density, blood sugar regulation, and local tissue changes with excessive frequency. If a first injection provides minimal relief, research generally does not support simply repeating the same injection expecting a different result. It is typically a signal to reassess what is actually driving the pain. Questions worth asking your doctor. Before deciding, here are the specific questions that the research suggests are worth raising directly with your physician. What is the primary driver of my sciatica? Is it predominantly inflammatory or predominantly structural compression? Given my specific imaging findings, what percentage of similar cases see meaningful relief at 3 and 6 months, not just at 2 weeks? What is the plan for the window of reduced pain? Will it include physical therapy or movement-based rehabilitation to address the underlying mechanical factors? And how many injections have I already had at this level, and what does that history suggest about likely benefit from another one? These questions shift the conversation from a single yes or no decision to a clearer picture of what the injection is actually likely to accomplish for your specific case. What to do during the recovery window. This is the part most patients are never told. Here is something that gets very little attention. And it may be the single most important factor in whether an epidural injection produces lasting benefit or temporary relief that fades within weeks. The 2 to 4 weeks following an epidural injection, when inflammation is at its lowest and pain is typically at its most reduced, is not a window to simply rest and wait. It is the single best window you will have to address the mechanical and muscular factors that were contributing to your sciatica alongside the inflammation. Research on outcomes consistently shows that patients who actively use this window for graded movement and rehabilitation maintain their improvement significantly longer than patients who treat the reduced pain as a finish line and simply return to their previous activity level or remain inactive. Here is specifically what the research supports doing during this window. In the first week after the injection, avoid high-impact activity, heavy lifting, and any sudden twisting movements, since the injection site and surrounding tissue need this short period to settle. Gentle walking is generally encouraged starting within the first day or two, as movement supports circulation and disc health without placing significant load on the treated area. Starting in the second week, when most patients are experiencing their peak reduction in pain, this is the time to begin addressing the muscular component of the condition specifically. The piriformis and deep hip muscles that may have tightened over months of compensatory movement do not loosen simply because the inflammation has reduced. Gentle stretching of these muscles, introduced gradually during this lower pain window, is far more tolerable and far more effective than attempting the same stretching during a high pain flare. By the third and fourth week, the focus shifts to rebuilding the activity tolerance that pain had restricted. This means gradually returning to daily walking, restoring normal sitting and standing tolerance, and reintroducing any activities that had been avoided, but doing so incrementally rather than all at once. A common mistake during this window is overcorrecting, feeling so much better that normal activity resumes immediately at full intensity, which can re-aggravate the underlying mechanical factors before they have had adequate time to stabilize. This is also the ideal window to address the dietary and lifestyle factors that influence systemic inflammation. Since the body is in a comparatively lower inflammatory state and consistent anti-inflammatory habits established now are more likely to become sustained long-term patterns rather than reactive measures only used during a flare. The research is fairly consistent on this point. The injection itself provides a chemical reduction in inflammation that typically lasts weeks to a few months at most. What determines whether the underlying condition meaningfully improves during that window rather than simply returning to baseline once the steroid effect wears off is what the patient does with that window. Patients who treat the reduced pain period as an opportunity for targeted rehabilitation consistently show better outcomes at the 6 and 12-month mark than those who do not. If your doctor has not discussed a specific rehabilitation plan to use during the post-injection window, this is worth raising directly. The injection and the rehabilitation are not separate, unrelated treatments. The research suggests they work best as one coordinated approach, with the injection creating the opportunity and the rehabilitation determining whether that opportunity translates into lasting improvement. This is general educational information based on published research. It is not a recommendation for or against an epidural injection for your specific situation. That decision belongs to you and your treating physician, who can review your imaging, your history, and your overall health picture. Use this information as the basis for a more informed conversation with your doctor, not as a substitute for one. Drop a comment and let me know if this was helpful. Subscribe for more research-based sciatica information every week. What the research actually shows. Multiple studies tracking epidural steroid injection outcomes for sciatica show a consistent pattern. Short-term relief within the first 2 to 6 weeks is reported by a majority of patients, with studies showing meaningful pain reduction in roughly 50 to 70% of cases during this early window. Long-term outcomes tell a different story. Research published in spine and pain management journals consistently shows that the benefit at 3 months is reduced compared to the initial weeks. And by 6 to 12 months, many studies find no significant difference in outcomes between patients who received epidural injections and those who received a placebo injection or conservative treatment alone. This does not mean epidurals are ineffective. It means they appear to work best as a tool to reduce severe acute inflammation during a flare, creating a window of reduced pain during which other interventions like targeted movement and nerve mobilization become more tolerable and more effective. Used alone, without addressing the other factors maintaining the pain cycle, the benefit tends to fade. This video is for educational and informational purposes only. It is not intended to diagnose, treat, cure, or prevent any disease or medical condition, and it is not a recommendation for or against any specific medical procedure. Whether an epidural injection is appropriate for you depends on your individual diagnosis, imaging, and medical history, and must be determined together with your treating physician. Any post-injection activity or rehabilitation plan should be guided by your physician or physical therapist based on your specific procedure and recovery. Do not disregard professional medical advice or delay seeking care because of information shared in this video. Dr. Michael Kent is a senior health educator with 20 years of experience, not a licensed physician. Viewer discretion advised. D. If you experience sudden severe pain, fever following injection, or any new weakness, numbness, or loss of bladder or bowel control, seek emergency medical care immediately.